Ready when you are, Galya.
Okay. Right. Good afternoon, everyone. Let's start off. It's 2 minutes past. Firstly, good afternoon to you all. Thanks for joining us. Those of you that have joined us before know that G-ECHO is hosted by the Gastro Foundation, together with Project ECHO from the University of New Mexico. You know it runs on Monday afternoon, 4:30. And this week, we are fortunate enough to have the India team joining us. So thank you. And obviously, thank you to Karen. So I've got 4 little sort of case scenarios, situations that I thought we could go through. I would like some participation, if possible. So if there are either volunteers or if I can just pick a name. Nothing scary about the situation, and the answer is always on the following slide, so not to worry if you don't know this. I do appreciate not all of you are in upper GI. So if that's okay with you, is there a volunteer for the first case, or can I just choose somebody? I can see the name, so I'm going to choose someone. Wanga, can I choose you? Are you there? No. Matt, can you do the first one then?
Yes, sure.
Why, thank you. Okay. So let's get going. So the first patient, Matt, is a 50-year-old gentleman that comes to you, and he's booked for a routine scope for his reflux symptoms. He's got a medical history of hypertension, surgical history. He's had an ORIF for his femur, and you are aware that he's had a previous peptic ulcer years back. And of interest to you is that he is a renal transplant patient, and he also was wise enough to have stopped his smoking at the same time of his transplant. So I'm going to show you his scope, just 2 static images. I do hope they project, but perhaps if you see, do you see anything there that concerns you? Or yeah, perhaps you can describe those 2 images.
Okay, the image on the right is a retroflex image, which looks reasonably normal to me. You can see the gastric folds. I don't see anything of concern. The one on the left shows what looks like the antral area, distal body and antral area, and there's no obvious mass lesions or concerns about ulcers or anything like that. But the color change does look a bit odd. And would be probably in keeping with a chronic gastritis, I would guess, but I'd want to biopsy that area just to make sure.
Yeah, so I agree. So there's a definite almost cutoff between the gastric body and the antrum. I'm going to tell you, perhaps it doesn't project so nicely, but I agree with you. It's quite pale, so there's a difference there. And if you were to go and look closely, you might notice that there's some increased vascularity. Would you biopsy this? I'm going to tell you, I would be thinking of atrophic gastritis.
Yeah, and I'd also be worried about intestinal metaplasia, perhaps. So I would definitely want to biopsy it.
Where?
Oh, where? Sorry. I would want to do multiple biopsies in the stomach, almost like something similar to gastric mapping. So I take biopsies. Obviously, if there's any nodular, I can't see the whole stomach. If there's areas of major concern that are perhaps nodular, then I would focus on those areas. But if it looks like this, I would take biopsy certainly from the antrum, the incisura, and then both greater and lesser curves on the body of the stomach.
Yeah. Why? I agree with you. So you're looking for intestinal metaplasia. Why are you biopsying the body? What are you looking for specifically?
I'm looking, well, for numerous things. I want to find out if there's H. pylori in the stomach that I can treat.
There you go. Yeah, so with atrophic gastritis, for those of you that don't do many upper scopes, your H. pylori migrate proximally up the gastric body. So you're not going to find them if they are there, if you just biopsy the antrum. Good. So atrophic gastritis, remember it's a loss of gastric glands and with or without metaplasia. And as you mentioned, Matt, in the setting of chronic inflammation, usually due to H. pylori or an autoimmune background. Would you consider doing any blood tests in this patient? And if so, what?
Sure, that's a good question. Yeah, they're certainly at risk of getting iron deficiency anemia. So you might do an FPC and just look at your MCV. I'm not sure about the autoimmune part, whether you're referring to something like pernicious anemia and whether you do a workup for that. Not really sure what else I would do.
Yeah, I think that's, you're going to look potentially for, as you said, iron deficiency anemia, B12. You might, if your institution allows, consider checking for antiparietal cell antibodies or intrinsic factor antibodies. But yeah, essentially that's fine. Would you offer this person surveillance endoscopy with confirmed intestinal metaplasia in atrophic gastritis?
Yes, I would.
When?
The question is when. Yes. I'm going to be a bit on the fence and say 6 to 12 months.
Okay, so I think that's a bit too soon. Purely, there's no dysplasia, nothing else. So your optimal endoscopy surveillance, little bit unclear, but the present recommendation sort of sits at about 3 years. So I think in general, people get a little bit hysterical about intestinal metaplasia, but do remember you must look at them at some point. So at 3 years. So back to our patient, you go and scope this gentleman now 3 years later. And this is what you see on, I do hope I've circled it because it's a bit difficult to see, but on retroflexion on the sort of lesser curvature side, you do see a bit of irregularity, nodularity, so to speak. And you biopsy that. And it comes back as high-grade dysplasia. Okay. Now, what would your plan be with this gentleman on his autoimmune, his immunosuppressants with this gastric high-grade dysplasia?
Sure. I would first of all want to make sure that my biopsies have been representative and that we aren't actually dealing with an already established malignancy in that area. So I would have a low threshold if I've biopsied it, have taken enough biopsies to re-biopsy him and make sure I'm not already dealing with a cancer. And at this point, again, try and address any other risk factors he might have. So if he's got ongoing smoking, if he's using NSAIDs, if there's ongoing H. pylori, address all of those at that point, and then take it from there.
Okay, fair enough. Would you consider resecting this? If it comes back still high grade, sorry, it comes back high grade again.
Yeah, I think that's a difficult situation. He does, even with no other risk factors, being on immunosuppression is certainly a risk factor for developing all sorts of malignancies, long-term immunosuppression. So he's certainly at high risk. And the fact that he's progressed to dysplasia is an indication that he is extremely high risk. I'll be 100% honest and say I'm not sure offhand whether I would go and resect him. I mean, this is high along the lesser curve. So you would be looking at something like total gastrectomy, which is certainly not a minor undertaking. So I'm not 100% sure.
Would you consider something local, perhaps?
Yes. So I mean, you can consider if it's a clearly defined area where there's something like an EMR or an ESD is possible. And that would certainly also be a good idea for getting a better tissue diagnosis if you can remove the whole area.
Okay, so let's do that. I'm going to go with that plan. That's what I did. Then you can debate whether it was the right decision later. Let's go on. So EMR, ESD for high-grade dysplasia or mucosal adenocea in the stomach, definitely an option. You should consider it only if the histology is well differentiated. If your area of suspected tumor or dysplasia is less than 2 centimeters in diameter, and you really do not want to be doing this if you've already got an area of ulceration or confirmed lymphovascular invasion on your previous biopsies. And obviously to get it off safely and as an R0, you want it limited to the mucosa, which brings me to the next point. Should you be doing an EUS in this situation? So ideally, yes. Obviously, as most EUS situations, it's very much operator dependent. So in my hands, probably not such a good thing, but perhaps Dion or Sean would do a better job. I would imagine so. The accuracy is, however, a bit debatable. That's the one thing in this situation. You may well overestimate the depth. And it's very less not very, but it is less accurate if you have an ulceration, or as we said before, if there's a size of over 2 centimeters. So a little bit, to be honest, I would always elevate this lesion. If it elevates nicely, there's no puckering, I would proceed to an EMR ESD. ESD is probably the way to go in a gastric lesion, and you mark it out and lift it up, take it off safely. And what we got back, Matt, was a high-grade dysplasia, but with a 4 millimeter focus of adeno-CA in situ. Fortunately, all margins clear. Okay.
Yeah.
So now, what is your plan with this gastric R0 adeno-CA in situ?
I think the correct answer is to bring this patient to an MDT and discuss it with a good oncologist.
Good answer, yes.
The fact that it's in situ, and if you're happy this clear, I don't know whether you'd go ahead and stage the patient formally. Certainly if it was anything more than this, I would formally stage the patient with a CT. But if we're happy that it's with clear margins and it was in situ, then perhaps you don't need to go any further, but it's something I'll discuss at the MDT. I mean, this is not something we ever see. That's why I'm struggling a bit because all our cancers are so advanced when you see them. So I'm not actually sure.
Yeah, that's why I'm bringing it up here, because this is such a rare situation. As you rightly say, we hardly ever see something so early, every now and then. So yeah, just to bring it back to this situation, do you CT scan? Do you rescope? Definitely go to the MDT. I think the main thing is definitely to involve the patient here, because although gastric CAs are at very low risk for lymph node mets and local recurrence, it does happen. Now, in this case, it would be the chance of that sitting, that tumor that we took out would be about 3%, because that's definitely a mucosal thing. But once it becomes a submucosal thing, look at that percentage, jumps up to 20%. So I think there you have to really stage this properly and run it through an MDT. Are you going to take it further than this? And I think that's really a decision that your patient has to be a part of. Yeah, but an unusual situation, and I can't remember except for this one, the last one that we had that was this early. Okay, thank you, Matt. Let's go into the next patient. I don't know who else is there. Is Yalda, are you around?
Yes, I am.
Do you mind taking us through this one, if you're okay with that?
It's okay.
Cool. So the second case is a 32-year-old lady. She's been previously well, no comorbidities that she's aware of. And she comes to you on an elective list, and her complaints on the referral letter are that she's having early satiety, some epigastric pain, and she thinks she's lost 5-6 kilograms over the last couple of weeks. She was given some empirical PPIs from her GP, and she says this hasn't helped her at all. So I'm going to show you the scope, 2 scopes, in fact. The first one, let's assume, is her. I'm going to show you the second scope, which is not her, but the same condition. I'm just trying to prove a point. So let's look at the first scope. So we're starting off in the esophagus, obviously. And if you can tell me if you see anything that worries you. Okay, and there we get to the pylorus. I'm going to stop the video there, but you're going to have to believe us. We could get through.
Okay, I didn't see anything, or maybe I missed it.
Okay. Okay, no, that's good. I'm happy with that. I'm going to show you a second video, same situation, but much more obvious. And then we'll go back to this one.
Okay.
Okay, here we go, starting at OG junction.
Is that a mass or foot? No, that's a foot.
So that's food, yeah.
There's some bulge there and some ulceration in the
Mm-hmm.
fundus. I'm not sure if that's the one. The mucosa doesn't look normal. There are lots of.
An unhappy mucosa, I agree. Okay,
They
let's
don't
stop
look
there.
fine.
Yeah. Okay, so my concern is on the, I'm going to go back to the first one, the first video, and I'm going to tell you what worries me there. So the esophagus, I will agree with you, looks beautiful. OG junction looks fine too. As you come through, the first thing, you don't generally see a puddle of fluid. Okay, then the other thing is, where are the rugae of the stomach concentrically? It's not really visible. And you get an idea that it's quite a narrow, restricted stomach with some extrinsic compression perhaps. But this stomach would worry me very much as to a linitis plastica type of diffuse infiltration of adenocia going laterally. So if you see a stomach that doesn't dilate nicely, you don't see nice rugae, be very worried. And I agree with you, if you look quickly, it looks pretty normal, but if you biopsy here, and specifically in this situation, you're going to have to do stacked biopsies because you want the deeper tissues. You might just get normal mucosa. So stacked biopsies when you think linitis plastica. The second video, very obvious. I mean, that is tumor absolutely everywhere. And I would suspect if you scope this lady a month or two later, it's going to look something like that. Why is there food there? Remember, the linitis plastica causes quite a stiff, leathery type of stomach. And even though you don't have an obstruction, you do not have functional peristalsis. So that stomach can't actually empty. So that's just to show you that's early-ish linitis plastica. You should pick up that there's something abnormal in that stomach. Okay, we've looked at that. Let's move on. Okay, so you've biopsied it. Let's go back to our lady now. And it confirms that there is a poorly differentiated adenocarcinoma and there are signet cells within that specimen. So what does that histology tell you? Are you worried about anything there? What does that mean to you?
I know the presence of signet cells, it means a more aggressive type of a tumor was poorly differentiated. So overall, it doesn't look a very good histology.
Yeah, so it's very concerning.
Poor prognosis.
Absolutely, I agree. On the history that we initially got from this 32-year-old lady, is there anything else now that you have confirmed this poorly differentiated carcinoma? Would you like to ask her anything else about her history? She's 32. Is that a normal age for a gastric CA?
The signet cell usually comes in a younger age group.
But a gastric CA at age 32, what are you thinking there? What's concerning?
Any family history?
Yes, absolutely. You want to know family history. So I'll tell you, she has an elder sister who died of gastric CA age 41. And she had a cousin, she can't remember the age, and an uncle on her mother's side, also in his 40s, who died of gastric CA. Okay. So that's the background there. So there's a bit of concern there. Yeah. So just let's talk quickly about histology as regards gastric CA. Let's quickly go through it. I think otherwise we're going to be a bit slow. But remember that specifically for this case, 85% of gastric CAs will obviously be adeno. And then it's intestinal, usually well differentiated, and in this poor lady, diffuse, poorly differentiated. Most of them are sporadic, but a small percentage of our gastric CAs will arise within an inherited gastric cancer syndrome. Remember, as the genetics of cancers become more and more dominant in the way we treat things, this intestinal and diffuse, I think at some point will fall away. And we're going to be classifying our histology more according to the genomic background. So it's going to be Epstein-Barr associated, microsatellite instability associated, chromosomal instability, or genomically stable. Go back to her. Can you think of any hereditary situations where you might have a increased gastric cancer risk?
I always get confused with these syndromes.
That's okay. I'll take you through them quickly. Can you think of anything? Something that's also colorectal, perhaps? Okay, let me take you through them. So if we look at all of the hereditary gastric CAs, we get about 10% show familial aggregation, but only 1 to 3% are genuinely true hereditary, as we would understand the term. The most common by far is the hereditary diffuse gastric CA, and that's where this poor lady is going to fall into. It's rare, autosomally dominant. It's usually in females, but not unheard of in males. And the problem is an E-cadherin abnormality, which is why they sort of grow diffusely. Then rarer situations, familial intestinal gastric CA, and GAPS, which is a gastric adeno-CA and proximal polyposis of the stomach. And every now and then we get a referral from our colorectal colleagues. It's usually a Lynch syndrome. Those are the only ones that I've come across in this situation that come with a gastric CA, and they're usually in their 40s, 50s, so a little bit older than the hereditary diffuse gastric CAs. Okay, good. Let's move on. You've now diagnosed this lady. What aspects of staging would you like to offer her?
So we can do a CT chest, abdomen, pelvis, diagnostic laparoscopy as a part of staging as well.
Mm-hmm. Yeah, I think that's probably those two would be top of my list as well. Let's just go through the whole thing. So scope and biopsy we've done. Would you check for HER2 receptor status? Well, possibly in metastatic disease. We don't know that yet. EUS we spoke about. That's definitely not recommended in this situation. It's far too advanced. CT, absolutely. PET CT, we generally do if we've got concerns for metastatic spread beyond our routine lymph node resection. And then also we use PET CT, much like you in HPP, where you're judging response after your perioperative chemotherapy. Tumor markers, not so useful in upper GI for adeno-CA of the stomach, so that's not something we would do routinely. As regards the T&M, pretty much the same as anywhere else. We're not going to go through this in detail, but it doesn't really change as regards depth, but it differs according to the nodal stage and the nodal numbers that are involved. So let's look at the CT. So I'm giving you 2 static images only, okay? From that, can you give me any thoughts on what you see here and what you would consider offering her? Yalda, you still there?
Sorry, I was muted. So the image on the right is showing some ascites concerning for malignant ascites. Yeah. I'm not sure. I don't see any nodularities in the peritoneum. There is some, the left image is showing some thickening of the wall of the stomach.
Yeah, so it's definitely a T4A there. You can see there's some nodularity beyond the actual wall of the stomach, but I agree with you. Difficult to say from this if there's any peritoneal mets. Possibly difficult to say if there's a plane there between the distal stomach. Yeah, but I mean, your ascites is a bit of a giveaway. That's done and dusted. And this is how they present. The linitis plasticas are absolute nightmare patients in that they will invariably come to you pretty late. What about her early satiety and a week or 2 weeks later, she comes to you with vomiting? Would you consider putting a stent in for this lady? Do you think that will help?
No, the stent will, I don't think the stent will help because it's not a mechanical obstruction, it's more of a functional obstruction.
Absolutely. Yeah. So a stent is a waste of time, unfortunately. If it's a situation where you know, here, if you had a very little ascites, you might consider doing a palliative gastrectomy here. I think it's one of the scenarios where you've got so little else that's going to help, and it's absolutely awful, vomiting absolutely everything that you eat. So we've done it on odd occasions, but gosh, they really don't do well. Within weeks to 2-3 months, it's usually the end. So it's a horrible situation to be in. Palliative chemotherapy, also awful. They don't keep much down anyway, so yeah, not a good situation to be in. Okay, thanks, Gelda. Well done.
Yeah.
You can mute yourself now. Who else is there? I saw Gert. Are you still around? No.
Yes, I'm still around. Sorry.
Oh, excellent. Good. Thank you. Would you mind going through with me for the next case?
That's fine. Yeah, 100%.
Great. Okay. So now, new situation. We've got a gentleman in his early 60s, and he's referred to your scope list with a history of an upper GI bleed, and his most up-to-date HP is 8.9. His additional complaints are epigastric pain, bit of bloating, and he's got no significant history. Otherwise, he is a smoker. I'm going to show you the scope, and you can just shout and tell me what you think. So we're starting at OG junction.
Okay, so again, poor gastric emptying with lots of food residue in there.
Mm-hmm. Sorry, I've sped it up a bit.
Okay.
Your eyes
The
are sharp.
pylorus looks deformed.
Mm-hmm.
And I see you can't really get through. Okay, so
Yeah.
there's definitely tumor-like growth here on the anterior surface of the greatest curvature. And even going into the posterior and well towards the lateral part, or sorry, superior part of the duodenum. This looks a little bit, I would say, abnormal. looks like a tumor there.
Yes, so you are on the ball, you biopsy it, and it comes back and confirms an adeno-CA. I'm going to show you now, well, what would you do next? So confirms adeno-CA. Next step?
Okay, so confirmed adeno-CA need staging then? CT,
yes.
chest
So
and
let's look at
abdomen.
this. Okay, so the CT is going to run through it by itself. If it's a bit too fast, just give me a shout and we can go back. Unfortunately, all the way from the chest down, sorry. Let's speed it up a bit. Trust me, there's nothing in the chest. Okay, I'm going to stop here at the mediastinum. Okay, there you go.
Okay, so looking for mediastinal lymph nodes, other lymph nodes. I don't see anything that jumps out at me. Right. Okay, so obviously the stomach very distended, but probably a degree of outlet obstruction there due to the tumor. Sorry, I missed the celiac. Oh no, it's there. Okay, I'm looking for nodes around the celiac. There might be some small nodes, nothing big. And then peripancreatic nodes, we will definitely keep an eye out for, which I don't really see.
No,
Don't see anything.
Okay, so just from your
no,
brief,
no ascites, and I had to look
Yeah.
at the liver as well. I couldn't see anything that jumped out from the liver either.
okay, so just summarize, what do you think?
So this looks like a quite a well localized lesion, so early lesion without clear evidence of lymph node metastases or distant metastases.
Yes, I'd
So
agree
I
with
would
that.
definitely go ahead with one would consider diagnostic laparoscopy for him as well as part of the staging again. But yeah, I think it's probably debatable. I mean, with a scan like that, it's very reassuring.
So yeah, I brought up staging lap a bit later, but let's talk about it now. Now that you brought it up, what would make you really push to do a staging lap?
Well, so in any if you have lymph node metastases or suspicious lymph nodes, I would go ahead, and then malignant or ascites would definitely be a reason to do a diagnostic laparoscopy. I would say that those two. I can't think of anything else right now.
Yeah, I don't know, if I saw ascites, I would almost say, okay, it's done and dusted. But what on scope would make you think, maybe I should do a laparoscopy? Yeah.
Sure. No, I don't know.
No, that's fine. So to me, it's very much a tumor size thing. So anything that crosses more than one anatomical region, so to speak, of the stomach.
So
here
this is really going into the duodenum, stomach into the duodenum. So,
but it's still pretty small and localized. So I would be happy if you said you're going to go ahead just with a CT as your staging. Okay, so we agree, early distal CA, resectable. Any plans for perioperative treatment?
I'm not too sure on the data. I know the move is much more towards perioperative chemotherapy. I didn't have such a close look on the scan as to try and guesstimate a T staging on that. But I know certainly anything T3, T4 one would consider the perioperative chemotherapy. So I would like to look at the images a bit more closely before deciding, and obviously going through an MDT to help make the decision.
Yeah, so I think that's fair. Always bring in the MDT. That's a good answer. And I would say anything T2 and onwards, you are being terribly old-fashioned, to put it nicely, if you are not offering perioperative treatment. Yeah. So yes, that's absolutely the way to go. What regime would you offer? And I think the most superior, although according to most of the data, we would be offering FLOT, which is fluorouracil, leucovorin, oxaliplatin, and docetaxel. And there's definite evidence to say that there's an improvement as regards outcome. So yes, so you're going to send for perioperative treatment. Let's just step out a little bit and look at the nodal stations, okay, for the stomach. So N1 lymph nodes, 1 to 6, and basically they are all sitting at the best way to remember it is sitting at the vasculature. N2, next branch of vessels, and then N3 are the distal ones. So just remember that doesn't correlate to D1 or D2, okay? Similar, but doesn't 100% correlate. So if you're looking at the gastric regional nodes, we would consider 1 to 12 plus 14 as being regional gastric nodes. Anything outside of that are considered as metastatic nodes, okay? So what would you say is a D1 or D2?
Okay, so the D1 resection would be obviously the perigastric nodes that you take out, and then the D2 resection would include nodes around the celiac axis, complete dissection of the common hepatic artery, taking the anterior leaflet of the transverse mesocolon, the peripancreatic nodes, and then the splenic nodes.
Yeah, the splenic one, the splenic ones are the the ones that there's a bit of debate about. The ones that go, yes, include those. The splenic hilum, you're offering a modified D2, or you can call it a D1 plus, which essentially excludes the hilar, the splenic hilar nodes as the main, change. We're going to offer her distal gastrectomy.
Yes.
Okay,
Yeah.
so for a D1, you're definitely going to include D1.
Yeah.
And then I would always do a modified D2 and always routinely exclude the hilar nodes. Okay. So we've spoken about that. Let's just look at it in slightly more depth. We agree anything less than a D1, that's a joke. That's not oncological at all. I think a D1 is okay if you've got a T1A cancer that isn't suitable for an EMR or EST. I mean, the chances that you've got anything more distal than that hopefully are quite small. A proper T1, you should be doing at least a D1 plus. But most situations, and I think, remember from Matt's discussion earlier, we hardly ever see something this early. We would usually routinely be offering a modified D2. A D2 plus, or what used to be called D3, is where they included para-aortic lymph nodes, and that is not really considered necessary. You should be getting at least 15 nodes, preferably more, otherwise you haven't done a good job, or you've got a pathologist who hasn't been looking very nicely at your stuff. I think, this is quite a nice article to go through, just summarizes it quite nicely, but there's not enough, there is enough evidence that in the West, routine full D2 resections don't benefit our patients long-term. So you can safely say a D1 plus or modified D2, which excludes the splenic hilum nodes, is the way to go. So those are the nodes you're going to be taking for this lady. Remember, we're going to get away with probably distal, a nice distal gastrectomy, absolutely, with a good Roux-en-Y. And yeah, exclude station 10. Just to bring this in, if you look at all the literature past, we in the sort of West would be doing very limited resections, and in the East, very extended resections. The two sides are sort of becoming more and more standardized and meeting each other in the middle. There isn't much survival benefit with para-aortic lymph nodes included into your specimen. Again, also not with a hilar dissection and splenectomy. Bursectomy, similar as regards just doing an omentectomy. We would just routinely do an omentectomy. So you're ending up with a scenario, everyone's sort of going down the midline, which is a modified D2. That would be, I think, acceptable in most units. You answered this briefly beforehand. Would you offer a staging lap? So in our situation, we pick up about a third of patients having peritoneal seedlings that didn't seem to have anything concerning on CT. So that's quite scary. And as I said to you, it's the larger tumors that you would offer a staging lap to, those tumors that cover more than one region or overlapping, and then definitely anyone with a poorly differentiated histology. Just the larger tumors, T2 even, have up to 18% positive peritoneal disease. So gastric series, it's really not quite as bad as pancreatic. It's really not a good thing to get. Your thoughts, laparoscopic versus open?
So if I'm doing it, it will be open.
Yeah.
Look, there's the extensive robotic gastrectomies with.
Definitely always what's safest in your hands. What is sort of get to see that once you're more comfortable, that you are fortunate enough to watch someone who's really quite slick laparoscopic robot, your lymph node yield really does increase if you're using minimally invasive surgery, whichever way you go. Full gastrectomy. Oh, you're going to have to really convince me hard that an open approach isn't as quick and as safe. I think for a total gastrectomy, definitely minimally invasive, I think is the way to go. These are partial gastrectomy, sure. I would also go with you and do it open. I mean, your time-wise, it's just as quick and it's fiddly. A partial gastrectomy laparoscopic is jolly fiddly. Okay, you're almost done, doing well. What are your thoughts on ERAS, post-gastrectomy for gastric CAs?
Right, so, I mean, ERAS, again, is a pre-operative and a post-operative thing, so you can't really say just only post-operative. Obviously, you need to, as well as you can, optimize your patient's nutritional status pre-operatively, limited your the fasting periods with your carbohydrate-rich drinks, even up to 2 hours before surgery. I would be a little bit more apprehensive with the gastric CA where you have a problem with gastric outlet obstruction, but possibly still sort of a modified approach to that. And then I would say early mobilization, chest physio, getting patients out of bed. Obviously, if one is doing it, but even with open surgery, you get them out of bed the latest day one, catheter out latest day one. I would start them on clear liquids also not later than day one post surgery if you're happy with the surgery. Then obviously your thromboprophylaxis has a malignancy, so one would use pharmacomechanical. Well, I would use pharmacomechanical thromboprophylaxis, and I would, yeah, I think that's about it.
Yeah, I think that's reasonable. So I think there's definite benefit, as you mentioned, to most of those sort of outcomes. If you look at length of stay, cost, flatus, defecation, all of those, mobilization, all of that. But be that as it may, bottom line to me, what is really important is there's no reduction in surgical site infection, no reduction in your leaks or post-operative complications in general. So brings you back to the end of it all. ERAS significantly increases your readmission rate post-gastrectomy. So I think while I'm very much pro-ERAS, I think it's not the same for upper GI as for lower GI surgery. I think there's a big difference. And those of you doing Whipples, there's things you can do to include ERAS protocols within your practice, but it's not the same as a colonic resection. I think we'll all agree with that. Upper GI is a bit of a different ballgame. So there's certain things that you just can't rush. I think for this specific patient, what would you have considered a reasonable nutritional support pre-operatively? Let's say she's vomiting up absolutely everything. What would you have done?
Okay, so if she's vomiting everything, obviously one wants to try and get the patient into the anabolic phase pre-operatively, or at least stop the catabolic phase. So if one if she's vomiting everything, can't keep anything down, not even liquids or semi-elemental, I would probably consider at least 2 weeks of parenteral nutrition for her pre-operatively, to try and optimize the function.
Yeah, I think
So,
I would agree with you. I think 2 weeks is sort of there's no definitive answer to it, but I think once you see an anabolic improvement and with the input of your dietitian, I think 2 weeks is fair. We would always try enteral, however. We would try and put a nasovaginal tube down.
Yeah.
I think, it's cheaper, it's better for the patient. So that's probably something we would do rather than parenteral. But I hear you, 2 weeks I think is reasonable. Okay, thank you, Gert. Well done. Let's move on to the last case. I don't know who else is here. Let's see. Anybody willing to offer themselves? Cecilia, are you here still? No.
I am
Galya?
here.
You
but
are
I'm
here. Yay.
a
Okay,
gastro-
good.
I'm not a surgeon.
No, that's fine, but you know this one. This is why I'm asking you. I left this one for you.
Okay.
And no, you don't have to be a surgeon to answer this one. So let's look at the last case, everyone. So this is a 58-year-old lady. She gives a proper history of postprandial vomiting, absolutely everything. You're quite concerned that it's taken her so long to get to you. She also reports at least 20 kilograms loss of weight over the last couple of months. And what's concerning is that she's been admitted repeatedly at the referral hospital for gastroparesis. And she's been started on TPN 2 days prior to the referral to your unit. She is a diabetic, she is hypertensive, and the surgical history, just for interest's sake, she's had a previous supraglottic malignancy resected, and she's had a lap chole. She stopped smoking a couple of years ago. Okay, so that's the history. I'm going to show you the scope. We're starting at the OGJ again.
So she's got significant food bolus. Otherwise, relatively normal looking gastric mucosa and normal gastric folds. Doesn't seem to be an obvious gastric outlet obstruction.
Okay, so you're going to have to believe me, I stopped. I could not get my scope through there. And if you put your biopsy forceps there, that's actually quite a pinhole opening. But I agree with you. The mucosa looks pretty unexciting, but you've got this giant food bolus there. And we shoved our biopsy forceps through the little pinhole. And on one of our biopsies, we've got atypical cells. Okay, so you are suspecting at least pyloric channel or D1 type of malignancy sitting there. Okay, happy with that?
Okay.
Then your next step, I'm going to show you a CT scan.
So she's obviously got a massively distended stomach.
That's huge. So let's just look at the area of interest. So you would expect your duodenum pyloric channel to be sitting there somewhere. You agree?
Yeah.
I don't know if you see anything there. That light up there is her surgical clips from her previous cholecystectomy.
It seems like it's completely obliterated. I can't make out a duodenum there.
I agree. I'm going to give you one more image, static image. Let's move on. That's probably okay. So that's a coronal static image. Anything you want to comment on there?
So again, the most pronounced thing is that the massive stomach that's dilated, and then it obliterates at D1 and it's completely obstructed, looks like.
Absolutely. Yeah, agreed. I mean, you can see her distal bowel is completely collapsed. It's a complete, very localized thickening, but I agree with you, completely obstructed. So I'm just going to tell you that from a performance status point of view, this lady is pretty much bedridden. She weighs 30-something kilograms. She's really not in a good way. That brings me to my to the next question. So what about palliative options for malignant goo? Can you think of anything?
So I mean, if you are able to pass a guide wire through there, then I would want to put in a stent, probably a bare metal stent, or covered, depending on what you have. But I mean, you're not going to remove it at a later stage. I mean, I wouldn't offer TPN in this patient if she's palliative. I mean, I don't think you're going to gain anything by that.
Yeah, I would also have gone with the first option as a stent. And we did so. We put her onto the next list, which was 2 days away. And then something happened in the ward following her admission 2 days ago. Remember, she also started TPN only 2 days ago. She
Yeah.
starts to complain of lower limb weakness, and you notice that she's got a bit of a slurred speech, and she's got nystagmus. So what on her history might explain this? What do you think?
So, I mean, if you've been giving her TPN and you haven't been supplementing thiamine, that could be a cause. I'm just trying to think of what else there was on her history. There was her previous surgery. I mean, she's a vasculopath and she's got a calcified aorta, so she could have had a CVA as well.
Yeah, fair enough. I think that's all things that you should consider. But I like the thiamine story. I think that's something that's underestimated. I know there's people that don't believe in refeeding syndrome. We've seen it do some pretty spectacular things. So I'm going to ask that you do think there is something like that, which brings me to the question, what risk factors, or what kind of risk factors, maybe not the right word, what profile picture in a patient would bring you to think of refeeding as a risk?
So I think anyone who's lost a significant amount of weight, so like your cancer patients, especially head and neck cancers or gastric cancers with outlet obstruction, your anorexic patients are another subgroup that can develop refeeding. And then if you look at other gastrointestinal problems, your patients with Crohn's disease, or really anyone that's lost a significant amount of weight and then get rapid refeeding, those are the patients that are at risk.
Yeah. So if you want to be quite specific about it, you divide them up into minor, major, and very high risk factors. You work out your BMI, so anything less than 18.5 puts you in a minor risk factor. And as you said correctly, more than any unintentional weight loss, that's either over 10% or over 15%. And then obviously your immediate nutritional intake, be it 5 or between or more than 10 days, will put you into either of those categories. The history of alcohol or drug abuse also falls under the minor risk factors. And then if you start a patient, the very initial bloods indicate a low potassium, phosphate, or magnesium. That's also quite a high risk factor to be noted. So anyone in our situation that presents with any of these risk factors, we would treat as a refeeding risk, and you should be supplementing from day one your thiamine, as you correctly said, because you want to avoid vernicus, and you would start at a low kilocal at about 10 kilocals, where normally you'd start at 25 to 30. So what actually happens, Cecilia? What happens with refeeding?
So essentially in a starvation phase, the main thing is that your potassium and your phosphate, they move into your out extracellularly. And then as soon as you start refeeding, you have a high glucose load and you have a high insulin load. And then basically with the anabolic state and with the insulin and glucose, you start shifting all of your electrolytes intracellularly, which then rapidly drops your serum phosphate and potassium, which causes the main problem. So you can get, all sorts from cardiac problems with arrhythmias. You can get respiratory depression because you get diaphragmatic weakness and aspiration pneumonias. You can get rhabdomyolysis because of the low phosphate. What else?
Yeah, that's beautiful. That's more than I would have been able to answer. So absolutely, very nice. So the big thing also to remember is the increase in extracellular volume. So that initial, once you've started your patient on nutritional supplementation, be it by whatever route now is available in that situation, that first kilogram or 2 is usually just fluid retention. So no point in getting excited there. But yeah, absolutely. Well done. Thank you. So we would start together with the dietitians with 10 kilocalories per kilogram per day. And you mentioned the thiamine being the issue, so she might be getting early Wernicke's. Okay, so you sort it out from that point of view. Now, you push in a stent with much sweating and cursing. You just get the guide wire over. And I hope it projects here, but this is the stent, and I've used an uncovered stent, and it's now 2 days, so 48 hours post-deployment. And you can see, I don't know, you can see that position. I hope
Very narrow waist.
yeah, so now she's continuing to vomit. What's happened? Or can you sort the situation out?
You can maybe try and deploy a stent within the stent. but I'm not
Yeah,
sure if it's gonna
okay,
open
fair
it up.
enough. What else could I try endoscopically?
You can try and maybe dilate it through there, but I'm not sure if
Yes.
that's
No, you
okay.
can, definitely. So that was our plan. I like that. So we tried to go back, put a guide wire through that super tight stricture, and then the plan was to pneumatically dilate that area. Couldn't even get the guide wire through. And I think you'll agree from this, it is an exceptionally tight stricture.
Yeah.
And you know, if you get partial opening, I think then I'd agree with you, there's some benefit to getting a second stent across. That double radial force sometimes does the trick. But in this situation, absolutely hopeless. We couldn't get anything across there. So what else could I do now? That's failed. My stent is absolutely failed.
At this stage, I would consult my colleague, Dr. Chinnery or Dr. Scriba, and ask them for a bailout because I'm out of options.
Okay, so fair enough. So the next step might be a surgical gastroject. Okay, agree with that. However, thinking back at this specific lady, she's a nutritional wreck. She's not a great candidate for an anesthetic, let alone a surgical procedure. Can you think of anything else endoscopically I might do? Could, not me specifically, but somebody might be able to do.
Geez, I don't know if it's a possibility, but to stent sort of beyond there from the gastric antrum to a further distal part of your intestine, but I think that would be a mess, and no, that's just me
Yeah.
using my imagination.
No, that's not just you using your imagination. That is definitely an option. So that brings you to the option of an EUS-guided gastrojejunostomy. And just to run you through it very quickly, the outcomes are apparently pretty good. And the long-term patency rates of those stents are actually better than the duodenal stents. And that makes sense because your stenting is actually far removed from the actual tumor. So you're not going to get much ingrowth there. And if let's just look at it together for time's sakes, but there's different ways to do it. The direct way you'd come through with a needle, pop your guide wire through into the duodenum, and then place a lumen opposing covered stent. Now that's all good and well, but if you go back to our imaging, you've got an absolutely giant stomach. So you'd have to empty that stomach first and then find your duodenum and then blindly poke into what you hope is the duodenum. Remember that duodenum is going to be collapsed because of your proximal obstruction. So I think a direct technique here might be a bit risky. So then your next option would be, if you can get a guide wire down, do so, blow up a balloon, and that balloon you should be able to visualize quite nicely with your EUS. Alternatively, what's probably the safest is to get a guide wire, what's the word? A balloon with a guide wire through it, double balloon. So you blow up both balloons, fill up that area with fluid, and then you've got a nice volume dilated bit of small bowel to get into. And then you put your lumen opposing stent there. Alternatively, you can go retrograde. So get in, pass your guide wire and feed it up. Or alternatively, simply do it the normal way. This to me is a bit silly. I mean, if you can do that, why don't you just put a duodenal stent? In our situation, that would obviously not be possible. So these are different techniques available to try and place an EUS-guided gastrojeg with a lumen opposing stent far removed from your tumor, so the patency is good. I've not done one of these. The literature reports the outcomes to be absolutely phenomenal. I don't know. I just think the potential for a leak in a nutritionally depleted person where you're actually making a hole, when you're creating a fistula, essentially, I don't know. That's just my personal opinion. I would always try first for a duodenal stent, I think. Okay, happy with that? Good. I think that's it. Karen, I think our time is up and I've been through all 4 of my cases. So I'm going to stop sharing. Yeah, not sure if Karen's still there, but to summarize, I think, okay, to summarize, I think it's gastric CA is obviously a huge topic. We've only touched on a few things here with a few scenarios, so hopefully you'll remember some of it. I do appreciate gastric CA is not everyone's cup of tea. I think most of you are HPB, and Cecilia, thanks for joining from Medical GIT. That's great. But yeah, thanks for joining us, everyone. If there's any questions specifically, you should shout now. Not really. Otherwise, it just remains for me to thank the ECHO team and thank you also to ECHO India for joining us today. The feedback forms are available on the Gastro Foundation website, and we encourage you to try and put some feedback in that so we can try and improve things. And then obviously, lastly but not least, thanks to the Gastro Foundation and Karen for always sorting out the admin so beautifully. Thank you.
Thanks for a great talk.
No problem. Karen, anything from your side?
Sorry, I couldn't get the screen up for next week's advert, but I think you mentioned it's Sean Burmeister, endoscopic ultrasound, the basics.
Oh, there you go. Maybe he can give us more information about the EUS GastroJet. We must remember to ask him. Good.
Great.
Thanks everyone.
Everyone.
Bye-bye. Have a good evening.